Hi everybody, welcome back to my channel. I'm Yesha if you're new here, and today we're doing another specialty spotlight, this time in emergency radiology. I am joined by someone I worked with when I was at MGH, Dr. Marc Succi. Thank you so much for being here today.
Thank you for having me.
He did his fellowship in emergency radiology, but also has a lot of outside interest, and we will get into all of those in just a minute. All right, so the first thing I like to ask everybody who does this with me is, how did you find radiology as a medical student?
Yeah, it's a good question. So I actually, as a med student, got involved. I liked anatomy a lot, so I got involved tutoring anatomy. Um, and for tutoring anatomy, we had a radiologist who was kind of like our faculty sponsor type person. So I got to shadow radiologist and learn a lot about radiology. And actually, when teaching anatomy, we would use a lot of radiology cases. For example, throw up an X-ray and show where a fracture is, and then go behind the scenes and look at the anatomy. That's kind of how we taught it. So that's what really got me interested in radiology, was the anatomy aspect of it, and also having a radiologist there at the medical school was, I think, a big factor for me personally.
Yeah, definitely. I think a lot of people get interested in it because of anatomy. I also really loved anatomy. That's why I chose radiology as well. And I've actually TA'd at Harvard Medical School, like helping show cases and stuff. I think that's a great way to expose medical students to radiology kind of early during their curriculum. So I agree. I think that's excellent. What made you choose emergency radiology out of all of the subspecialties that exist?
Yeah, another recent question. So I guess emergency for me, I felt like emergency radiologists were kind of like the generalists, like ED docs would be the corollary. So you see a lot of material. You see from neuro to chest to body to extremities. You see a lot. A few other things is that you're actually able to make pretty much an instant change in a patient's course. So a lot of emergency medicine relies on imaging to dictate essentially the path. So it may be the difference between going to the OR and sending the patient home might be your read and abdominal CT scan. So it's very gratifying to get that instant feedback. And it can be feel like pressure, but it's also very gratifying to be in that position. So I would say that was the other thing that was interesting. And compared to the other radiology specialties, I felt like in emergency, there was a lot more of seeing a patient for the very first time. So the very first CT scan they get, you might be looking at it, and a lot more frequently than if you were in another division. So you really have undifferentiated patients at a higher prevalence than other divisions. And this makes it interesting because you're not biased. You're not following up perhaps cancers. You're actually looking at the patient for the first time. And what you say in that report not only changes care at that moment, but it may dictate their follow-up care for years to come. So again, it really allows you to have an impact on patient care. And that's what I found most interesting. As part of that, you get to talk to the teams a lot. You talk to the surgery teams, the trauma teams, the medicine teams. They're all at a higher rate, I think, than other divisions. And, at our institution, they're all very friendly. And this is very collegial and academic, and I appreciate that.
Yeah, I can totally see that. In fact, when we're doing our overnights, I think it's kind of the same thing. You're seeing everything, a lot of things for the first time. And yep, people love to come down and talk about what we're seeing because, as you said, it impacts patient care.
Yeah.
Is the person going to the OR right now or not? You're the one who's deciding that. That being said, what does a week or a day or a night look like for you?
Yeah, so I think in general, my schedule is a bit different, but in general, an ED radiologist might work, at an academic center 4 or 5 days a week. And, if they're on the day shift, it might be something like 7:30 to 4 or 7:30 to 5, and you go home and do that for 4 or 5 days. If you're working the nights, you may come in at 11 p.m. and leave at 7:30 a.m. and do that for 7 days straight, take 2 weeks off, do a few shifts in that last week, and then start the cycle over. A lot of places are built like that for nights. For me at an academic center, I spend probably about 40% of my time doing clinical work. So that might average like a day and a half to 2 days a week clinically, being either day or evening. And the other time is really split between research, administration, and working for my hospital system, Mass General Brigham, doing various things in the innovation world. So for me, my clinical time is probably a little less than the average. But again, in an academic center, it's people work full-time clinical, minimal time clinical, I'm kind of in the middle somewhere. So.
As an emergency radiologist, I mean, you mentioned like, you're in academics, but do you feel like you're confined to academics as an ED radiologist, or are you confined to a level one trauma center or anything like that?
No. I mean, ED radiology, the nice thing about it is you get breadth in so many different facets, and you stay up to date on so many different modalities and body parts that you can really, you can go to private, you can go to telerads, you can really do anything with that skill set. It's not limiting. That's not to say if you become a neuroradiologist, you can't go back and learn body and change the type of practice you work for. But I think with ED, that activation energies are probably a little bit lower because you're just doing it so often and so much. It's constantly the general aspect of radiology. And the other thing I'll say about that is that's not to say that you don't get into specifics. You don't get into subspecialties. And there's a lot of people, radiologists in our practice, who are brilliant in niche, for example, internal hernias or deep spaces of the head and neck. And you probably remember a few of the teaching sessions from the MGH radiologist. But just because you're a general radiologist does not mean you can't really dive deep into specific either modalities, body parts, stuff like that. So you really can do anything, I think. And that's kind of the cool part of emergency for me.
Yeah, I agree. And I think actually a lot of people go into it just for the other reason that you mentioned, that you can end up doing like 7 days on and 14 days off. That lifestyle really vibes with a lot of people. At least that's what I've heard from a lot of my attendings who are on nights with me, things like that. So that's great. Sounds like a really nice and flexible. You can kind of tailor it to what you want.
Right.
But as you mentioned earlier, you have a lot of outside interests. You do a lot of innovation work. Tell me a little bit about that. Was that easy to get into?
Yeah, so for me, I took a year off in med school and went to MIT, worked in stem cells, invented a device that we licensed out to a company that became public, and so that was like my first introduction to the whole innovation sphere. So I kind of fell into it when I got to my residency. For us at Mass General and the Brigham, there is a lot of innovation work. So by no means what I was doing super new or anything, but for me, I became, I think, a resource for a lot of the other radiologists and clinicians to ask, how do I get a patent? How do I license out this technology? How do I start a company? And I started a company before. So I kind of started educating in these areas and then formalized it as something called the Mesh Incubator, which is now an incubator across all of Mass General Brigham. And what we do is we help clinicians and researchers take ideas from their head, put them on paper, which is the most difficult part, I believe, of innovation. And then make a beeline towards a product which you may start a company out of or you may license. And to do that, we have like 4 or 5 different programs at this point, including a biodesign year-long program, an educational program, and a prototype accelerator, and a few others. So that's kind of my innovation work. It is basically helping others to make their ideas become a reality. Additionally, we do a new division in this is called Innovation Operations, or Mesh IO, and it's a lab that I recently started. I have about 20 students in the lab and residents, and we essentially look at operational aspects of innovation from an industry standpoints and operational aspects of radiology departments. So we look at things like ED utilization of imaging or predicting if this patient is going to get a CT scan based on what complaint they come into. And that obviously translates to dollars at some point, which is important for healthcare systems to understand. So that's kind of the non-clinical stuff I do.
That's awesome. It sounds really fascinating. I know a lot of radiologists end up getting involved with like technology, innovation, as you're mentioning, AI, that's the buzzword that everyone's talking about. Yeah. Is it difficult to get involved as a radiologist, or is it more like something you really have to work towards?
I think a lot of it depends where you are, but less so than before, right? Because before COVID and now everything's virtual, I mean, we're doing a virtual interview, is that you can connect either, through the RSNA, through the ACR, to numerous innovative radiologists across basically the world, and work with people either on research and innovation. You can probably work with people from an industry standpoint using those platforms. So for me, I think that the activation energy was a little lower because I was kind of in that system at MIT and Harvard. But you don't have to be in a big city to especially now, to get into the innovation realm. So I think now more than ever before is an opportunity for people looking to get into innovation in medicine.
I think that's really, again, something that medical students really look towards radiology. It can be a negative or a positive. I know some people believe that this is going to take over radiology. We all know that's not true, but
Yeah.
I think it's very exciting. As a radiologist, it's very easy, at least from what I hear, it's easier now than ever, like you said, to get involved with industry. And I definitely think that's kind of where the future of radiology lives. So I'm glad you were able to speak to that. Just in general, do you recommend emergency radiology? Who's a good fit for it? Any general advice?
Yeah, I definitely recommend it. Obviously, I love it. Again, I feel a little bit almost old school at times, being a generalist radiologist. It's not a real term, but I like it a lot, and I think it suits people who do want a little more of that shift work type lifestyle, or do want that ability to have 2 week stretches where they're not doing clinical work. They may have a company. I mean, some people do. They may have a technology they work on. They may have a lot of research or run a research lab. So I think emergency gives you that flexibility. It gives you that generalist feel, that kind of old school feel. And I think it's definitely very social. That's not to say other divisions aren't social. But the social aspect of it is something, working with other teams, interdisciplinary teams, is something I believe a lot of people enjoy in medicine, and certainly something that I value a lot. So, if any of those three things are interesting to you, I think emergency could be a good fit in radiology.
I forgot I wanted to ask you one more question. Do you ever do procedures? Maybe, I don't know if you do it in your practice, but does emergency radiology ever control any of the procedures that come through?
So at my specific institution, emergency radiologists don't do procedures. At other institutions, especially ones that aren't like a level 4 trauma center, um, definitely emergency radiologists might be the ones doing procedures, inserting NG tubes on the fluoro machine,
Right.
doing barium swallows overnight, leak studies. So there are definitely things I think emergency radiologists do procedures in, if that's what you're looking for. But so much of that is practice dependent. And I'm, on my end, I don't do procedures. So,
Yeah.
um, our practice is a little bit different like that.
Yeah, I mean, you can basically find like MSK with procedures, MSK without procedures, body, same thing. So I think that kind of goes for everything. But anyways, that was really my last question. Is there anything else you wanted to say or discuss? You can.
No, I would just say radiology is great. I think it's one of the specialties that is constantly increasing in value in terms of what we provide to the patient. I think radiologists are being more patient facing, and there's more of that if that's what you're looking for. And lastly, to get involved on the innovation, the research realm, this applies to radiology, but also other specialties and medicine in general, is that now is a great time to connect to other institutions that may have expertise that yours doesn't, being in the virtual world at all. So you're in a great spot. Go for radiology and let me know if you have any questions. And thank you, Yasha, for putting this together. It's so important to have mentoring and outreach like this, and we value it so much. So thank you.
Of course, it's my pleasure. I love radiology, as everybody knows, and I love to share it with the world. So I'll do anything I can. But anyways, thanks everybody for watching this video. I will have Dr. Succi's information and his Twitter linked down below. So feel free to reach out to him if you have any questions. And I will see you all in the next one. Bye.